Hi, everybody, and welcome to our clinical Q&A panel. Today, we are going to be chatting with Dr. Lucia Seminario-Vidal. Dr. Seminario-Vidal, thank you so much for being here today.
Thank you so much for having me, Hilary. It's always a pleasure to be in here.
We are thrilled to see you. I know some of you may recognize Dr. Seminario-Vidal. She has also done one of our Answers from the Experts live for us and is also a member of our Medical Advisory Council. So we are super grateful for your time. And we're just going to jump on in here today. We have a ton of questions from the day. And folks, you can keep submitting those online in that Q&A icon. And we are also waiting on Dr. Jasmine Zain. She will hopefully be joining us in just a few minutes here, but we will go ahead and get started. Let's see. Okay. So I'm going to dive on in. Our first question is, when do sporadic periods of extreme sweating at night become worrisome? This has happened for a week or two, but then stopped for months. So I don't know if this is as related to their disease. Sorry to start you off with a complicated one, Dr. Seminario.
No, actually, it's a frequent question that we have. Okay, and the first thing that you said is completely true. Is it related to the disease? Like most of the time, I will say it's not. I will be more concerned in a patient with an advanced disease stage, like Sezary syndrome. They start like sweating profusely, and that is consistent. There are multiple reasons why somebody has sweats at night, like hormonal reasons, physiological reasons, changes in weather. There are the most common causes. But I will say, if you're been consistently sweating, if you are like losing weight, we call those the B symptoms. I will be a little bit more concerned about a B-cell lymphoma than a T-cell lymphoma. And also, if, like I mentioned at the beginning, if it lasts several weeks, I would say at least 4 weeks, it's consistent every night. It's not something that's stopping. Bring it up to your doctor at that time. It will be extremely rare to be related to CTCL in an early stage. I don't think I ever seen it ever like related to early stage disease, only and rarely in patients with Sezary.
Okay, that's good information. Thank you. Let's see. How important is it to insist on a diagnosis if the treatment recommended, and in parentheses, they have light therapy, seems to be working? How does one insist on a diagnosis? So I assume that's before, or if they were receiving treatment for an earlier stage.
Yes. So as I think as everybody knows, a cutaneous T-cell lymphoma is extremely difficult to diagnose. It's very challenging. And many times, even if we put the clinical presentation with the pathology, the molecular studies, we may not have a definite diagnosis. It takes like an average of 4 to 5 years to diagnose cutaneous T-cell lymphomas. So in the case that somebody has the suspicion for cutaneous lymphomas, or I think in some centers, they say they have like an atypical lymphocytic infiltrate in their biopsy with no clonal cells in the molecular studies. The treatment that these patients receive, like, is usually skin-directed therapies. I will say, if you're responding to the treatment, like it's up to a discussion between your doctor and yourself. I have some patients that if they're responding to treatment, they are happy with that. They don't want to have more biopsies, more studies, because they're responding, they're doing good. I have other patients that they really want to get to the bottom of it, because they want to have a final diagnosis, which I will say, if you're getting better, it will be more difficult to get because there will be less disease skin to biopsy. And that's like the best method that we have so far to diagnose it. But if you're getting worse, I think then like I will suggest to my patients to try to rebiopsy and see why they are not responding to the treatment. And many times, because an area is getting worse, is because the disease is progressing in that area or is more difficult to treat, and then we can advance the treatment options. So in summary, it's a discussion with your doctor, and depending how you're responding to the treatment.
Okay, great. Thank you. I was diagnosed last week with MF. One of my biggest symptoms that I'm struggling with is chronic exhaustion. Is this a known symptom of MF, and does it get better with treatments? If so, what treatment is recommended for exhaustion? Thank you. And I see we have Dr. Zain joining us too. Let's see, are we able to pull her in here with us, Simeon? Just one moment, folks, sorry. Maybe Dr. Seminario, would you be willing to start that question out?
Sure. So I will repeat the question is if exhaustion is a symptom of MF.
Yes.
So when we say MF, we're usually thinking like early stage disease. And in patients with early stage disease, it's extremely rare to see exhaustion related to the disease. But we see fatigue and exhaustion related to anxiety. And I believe, and there are like studies that support that many patients like suffer for anxiety because it has been taking so much time to diagnose them. So it could be more related to the anxiety related to the disease than related to the disease itself.
Okay. And we have Dr. Zain with us here today too. Hi, Dr. Zain. Thanks so much for joining us. I'm sorry for the last minute snafu, but we're glad you're here.
No worries, no worries. I'm just in my car, so I hope that's
no
okay.
problem.
Yeah, yeah. This is the magic of virtual, virtual meetings.
Exactly.
So I would say, I think it really depends on your stage and what treatment you are getting. There are certain treatments that are associated with fatigue. For example, HDAC inhibitors. If you're getting them, even the oral, fatigue is a known side effect. I think, as mentioned earlier, the anxiety associated with the disorder, the lack of sleep, things like that are definitely contributing to the fatigue and the can. So we need to just kind of keep that in mind. But fatigue is always a very difficult symptom to attribute to any specific cause. But as I mentioned, certain treatments are associated, especially romidepsin and vorinostat. Sometimes chemotherapy, if somebody's getting aggressive chemotherapy, that would also be an issue. It can cause fatigue. So, but in early stage, it's really related to more anxiety, difficulty sleeping, things like that. Mm-hmm. Another aspect to remember: if you're on targretin or a retinoid treatment, it can affect your thyroid function, and if the thyroid function is not adequately addressed, low thyroid is also another cause for fatigue. That could be another problem.
Good to know. Thank you. Is losing all of your facial hair, they've noted scalp, beard, ears, eyelashes, and eyebrows. Is this a symptom of either folliculotropic mycosis fungoides or just standard MF? And are there different therapies, treatments for FMF as opposed to MF? So kind of a big question here. Dr. Seminario, are you willing to start this one off?
Sure. Yes. So I think the area will need to be evaluated first, like in patients with folliculotropic MF, in areas that are hair bearing, we notice hair loss, but there are plenty of causes of hair loss. So I'll recommend first a biopsy. Always, we need to keep in mind that cutaneous T-cell lymphoma is a rare disease, and we can see it associated with other dermatological disorders. So if it's diagnosed with folliculotropic MF, after a biopsy is done and analyzed, the treatment is in some stages could be like similar than mycosis fungoides, but we need to remember that it affects the hair follicle. So we need things that go deeper in the skin. So many of the creams will not go to the hair follicle. So you will need some type of gels that will go deeper, or like some type of skin directed therapies, like light therapy that goes deeper in the skin, like PUVA goes deeper than narrowband UVB, or total skin electron beam radiation. If somebody's worried about hair loss, radiation causes hair loss. So I will not choose that treatment depending on the area that's affected. And it seems the person asking was saying scalp and eyebrows. But first I will check what it is, because it could be not related at all with CTCL. It could be another dermatological cause.
Okay, anything to add there, Dr. Zain, or should we move on?
No, I think again, hair loss for folliculotropic MF is very common at sites of disease. And generally the way we look at it is I try to treat it with as if it was a slightly more advanced stage of MF, if it's folliculotropic MF, because it's one of those conditions where the prognosis is a little bit worse for the same stage of non-folliculotropic MF disease, just because the disease goes deeper into the hair follicles and some of the topical treatments don't get down there. So using systemic treatments like bexarotene earlier on, then, is probably needed for these patients. So,
Okay,
yeah.
Thank you. Should patients who have MF avoid melatonin? At one point, I wanted to take it to help manage jet lag, but my PCP at the time told me it might affect my immune system and have a negative impact on the MF. He was not familiar with the disease. Any insight?
Take
Dr.
that
Zain?
answer. Yeah. So I'm actually not aware of melatonin being associated with decreased immune system, any effect on the immune system. I think it might have been just one of those situations where he was erring on the side of caution. So I think melatonin is fine in patients with MF. I actually prescribe it a lot. It's much better than using sleeping pills. So.
Okay.
Yeah, I completely agree. There is no studies that show that melatonin will affect cutaneous T-cell lymphoma, and it's good for sleeping. So there should not be a contraindication. But yeah.
Okay, thank you. Let's see. I will probably begin treatments next week after meeting with my doctor at MD Anderson. If I do the light therapy, can this be done at home with a light box? I ask this because I do not live close to a hospital. Thank you. And this question came up several times in one of our networking groups today. Dr. Seminario-Vidal, any insight on this one?
Yeah, so I think there are two thoughts about this question. Some of my colleagues, depending on the patient, will prescribe a light box for the patient. I personally don't prescribe a light box for my patients. I find who's the closest dermatologist, because personally, I think some patients progress when they have their own light boxes. They forget to go to their appointments, and when they come to see me, the disease is more advanced. But like I mentioned before, other of my colleagues will prescribe the light boxes. So it will be a discussion with your dermatologist. And the reason I don't prescribe it, but I have a map of all Florida who has a light box, who dermatologists will have it. And I will tell my patients who's the closest one to them so they can get treatment and somebody can supervise for side effects.
Okay, thank you. And let's see here. Dr. Zain, is there any ongoing studies to see if you have MF, if your chances of getting other types of cancer are increased?
So generally, that's an interesting question. I can tell you that there is some association with MF and possibly later on or at some point developing another hematologic malignancy like a lymphoma. The association is kind of weak. There is also some association with chronic lymphocytic leukemia. Other than that, I'm not aware of any associations. Now, a lot of patients end up getting light therapy, which, again, light and ultraviolet radiation and all that can be a risk factor for skin cancers. So, and I know my dermatology colleagues do monitor, that's one of the reasons you need to be monitored if you're getting light therapies, that if you're developing any of these skin lesions that maybe, eventually lead into skin cancers like basal cell carcinomas and squamous cell carcinomas. But in terms of solid tumors, I'm not aware of any associations.
Okay. I have been diagnosed with pcALCL in January of this year. My first breakout went away on its own after 8 weeks. Since it went away on its own, why do I need to get a biopsy every time I have a breakout? If left untreated, what will happen?
Okay, do you want me to take that one?
Sure.
Okay, so, primary cutaneous anaplastic large cell lymphoma is a lymphoma which actually has a very good prognosis, but it can also overlap with something called lymphomatoid papulosis. It's sort of a spectrum of these CD30 positive, what's called lymphoproliferative disorders. And the LYP or lymphomatoid papulosis typically has a clinical characteristic of waxing and waning. And as you mentioned, your lesion went away in 8 weeks, so it sounds like it might be an LYP lesion. And I agree, I don't think you need a biopsy every time. I think I would, once the diagnosis of this thing is confirmed and you have a clinical behavior, your doctor should just follow you with the understanding that these things will come and go. Of course, if they become clinically significant, meaning they're causing troublesome, it is in an area that's causing irritation or on the face or something, you may need some treatment. I think the time to biopsy would be when the characteristic of these lesions changes. If they become more tumor-like, ulcerated, seem to grow a lot faster, because it does overlap with this actual lymphoma, which is a primary cutaneous anaplastic large cell lymphoma, which will not go away by itself without some kind of treatment. So I would just work with your doctor, make sure they monitor you, but I agree, not every lesion needs to be biopsied.
Okay. Anything to add there, Dr. Seminario-Vidal?
Yeah, I think the challenge is very challenging to diagnose based on pathology. Yes, LYP or cutaneous anaplastic large cell lymphoma. You need to put the pathology together with the clinical presentation, and that's what your specialist in cutaneous lymphoma will do. And the fact that 8 weeks, after 8 weeks, the lesion went away by itself, like I agree with Dr. Zain, it's most likely LYP. Sometimes LYP can be tricky because it could be a larger lesion, not like the small papule that we normally see described in the books. But yes, the behavior will tell your doctor that it's not a primary cutaneous anaplastic large cell lymphoma. If your doctor is concerned about anaplastic large cell lymphoma, discuss with them why they're concerned. From what we're hearing, it seems it's not, but it's if they're very concerned for that, discuss with them why not.
Great, thank you. Dr. Seminario-Vidal, is sunbathing the same as having PUVA to help stage 1B? And is it okay to have bexarotene in conjunction with PUVA?
So the first question, is sunbathing the same as PUVA? Is not the same. Sunbathing, you are getting exposed to UVA and UVB, two wavelengths, and sunbathing has a higher risk to develop skin cancers than light therapy. Light therapy includes UVB or UVA therapy. Both can be combined with targretin. There are studies that PUVA combined with targretin give better results than PUVA alone, especially in folliculotropic MF or darker skin types. Same thing, narrowband combined with targretin. I will recommend against sunbathing because it's not dosage, it's not measure, and your risk of developing skin cancer is higher.
Okay, thank you. General question, would you say that there are better climates to live in that would help prevent severity of outbreaks? I'm not sure if either of you can answer this one. Dr. Zain, any insight on this?
No, again, I don't really know, but sometimes I know my dermatology colleagues have talk to patients about, we do see some seasonality in these lesions sometimes, so in the summer, they seem to be less of a problem than in the winter. Maybe the exposure to the sun, voluntary or involuntary, does make a difference. But I think, I mean, we can't recommend somebody to move to a sunny state. But, as you mentioned, this sunbathing is not really a good idea because you do get exposed to unnecessary radiation and ultraviolet that's not desirable, and the dose is not very well monitored. So I would say, no, we don't have any specific recommendations. I don't know, okay. Maybe.
Fair enough.
Yeah.
Let's see, stage 1A, 1B, if UVB is managing it, but still have periodic patches, what ongoing medical care is advised? What type of doctors, how frequently, what lab tests? Kind of a big one there. Dr. Seminario-Vidal, anything on this one?
I think It depends is the first answer. If UVB has put you on like complete remission, you have a complete response, like with no lesions, and you may get one small patch every now and then, like other skin directed, like topicals will be good to manage this. And when I say topicals, topical steroids, topical like nitrogen mustard, imiquimod, retinoids are good options. And but if it's controlling it and then you have breakouts with like large skin involvement, then it's not controlling it. Then the treatment needs to be changed. So I will talk to your doctor if the breakouts are really extensive, so they can either add something like combine light therapy with another skin directed therapy or a systemic therapy like targretin or interferon, or change it to something different.
Okay. Let's see. COVID vaccine done, but concerns if we, in parentheses, blood cancer 1A or B, have antibodies. Primary care doc says, don't do the antibody test. Do you have any other opinions? Dr. Zain, do you want to take this one?
Sure. So the antibody tests are, first of all, the stage 1A and 1B, I think doesn't make a huge amount of difference in terms of, whether you're immune or not, because it's kind of early. We do consider even early stage MF to be slightly, give you a little bit more immunocompromised, but it's not like you have advanced stage disease. So in terms of antibody, that actually applies to everybody. Antibody testing, the antibodies are not, first of all, they're not standardized, and in our infectious disease doctors are not recommending, even in healthy, I have asked a few times, should I get my antibody levels tested? And they are not in favor of that because they don't think it predicts the whole immune response. I know some physicians are following it, and I think that's something you can discuss with your primary care physician. But in general, the antibodies that are available for outside research facilities are perhaps not as reliable an indicator of your the complete immune response to COVID-19, which is not just antibody-based, but also cellular-based. And so it's still a question that really is largely unanswered. And different people are taking different approaches to it. As I said, our experts are actually telling us don't bother. Some people are getting them done even on their own, privately, to sort of like a peace of mind kind of thing, but I'm not sure if we have that information yet. So those studies are coming. I mean, all the vaccine trials are being monitored. People are being monitored with specific antibody tests. So we will know more about this down the line if this, this is something useful that we can follow. I would just follow the CDC guidelines at this point, and that's what I tell all my patients.
Okay. Let's see. What advice regarding getting full care and support if I currently have no access to a dermatologist with real experience? I have early stage MF. There are no doctors in the state I moved to 5 years after being diagnosed.
So I think here I could, the virtual platform is great these days. So you could certainly even call our institution or one of the larger institutions throughout the country and ask for a televideo visit with a specialist, a dermatology specialist. You can get a list from Hillary, for your closest one, or you can even talk to more than one person. A lot of physicians are more than willing to do televideo visits now. They're well established, and certainly for skin related issues, you can certainly show your lesions on the camera. So I think that's one option. You can get recommendations from the expert. You can send them your pathology reports, your records, whatever, and you can have a consultation. I think that would be the best way. And then when you get a chance, you can go see them in person as well. And then maybe coordinate their care with your local dermatologist who you're working with. And this could be a compromise. And,
just also in regards to support, we do have our networking groups monthly, and those are virtual still. So regardless of where you're living, we invite you to participate in those. And then we also have our community connections. So please take advantage of those. You can sign up for that through the website. Let's see, Dr. Seminario-Vidal, best treatment for stopping hair loss in the scalp, face, and eyelashes. And they've noted that their face and scalp are covered with 80% MF. Any advice?
Well, I think the best treatment is to treat the MF. MF needs to get treated. So as we were mentioning early, when it's folliculotropic, there is involvement of the hair follicle. So you need to get treatment for your MF, so it will help the hair regrow. There are multiple things that can help regrow, but if the bottom line, the reason that's causing the hair loss is not treated, it will not come back as it was before. If there are little things that can help, I always say topical Rogaine helps. Like it will make hair grow wherever you put it, but will not stop hair loss. So it will make some new hair grow, but will not stop. There's some vitamins that also help hair growth that you can buy over the counter, but also they will not stop the hair loss caused by MF.
Okay, thank you. I am 48 years old from India, and I am diagnosed with MF at the patch stage. I am trying to understand how fast can this progress. Is it possible I have faster progression than the average? If so, how do I monitor, or what should I monitor? I'm not sure I get the kind of classifications of the stage that is generally done in the US.
Well, I mean, I think in terms of this disease, the progression of this disease in any part of the world is very unpredictable. It sounds like if you have patch stage disease, most of the time, most patients up to 80–85% of the time will continue with early stage disease. It doesn't progress to, transformation or Sezary syndrome or some of the aggressive forms. So most patients will have an indolent disease. Only time can tell what the real course of your disease is going to be in particular. So I think just working with your dermatologist and keeping close follow-up, we don't actually have predictive markers at this point to say who will progress and who won't, irrespective of race or geography. As far as I know, there is nothing specific about, the genes from that part of the, people coming from that part of the world where the prognosis is worse. We know that it's a little bit worse in African Americans, but other than that, I'm not aware of any other racial influence on the actual prognosis of the disease.
Okay.
So
thank you. Is topical targretin prescribed for pcALCL? Doctor, take this one.
Yeah. She gonna answer?
Oh, okay. Sorry. I said Dr. Zain. I'm sorry.
Oh, okay. No, I'm sorry. I was kind of like, okay, I'm not
sorry
sure. No worries. I will let our dermatology colleague answer that question, really, with the topical steroids. Yeah. So
if it's primary cutaneous and aplastic large cell lymphoma, we don't recommend like topicals, and we usually recommend radiation therapy. For LYP, which again, I think similar to the other question, sometimes can be confused based on the pathology, not on the clinical presentation. Yeah, we use topical targretin and a lot of topicals.
Okay, right. Thank you.
Steroids, yeah.
Dr. Seminario-Vidal, someone has noted that they are MF1A in remission, but they have had some itching. Is the itching a preamble for a resurgence of MF activity?
Good question.
Dr. Seminario-Vidal, do you want to take this one?
Yeah, sure. So I don't think there's a study that shows that itching indicates that cutaneous T-cell lymphoma will return, especially if it's an early stage. Like I think the question is stage 1A. If you have specific areas that are itching, like I will have that evaluated by your dermatologist. Sometimes there could be a very faint patch that you may not be able to notice and need to be evaluated under better lighting. And it could be a lesion there that's itching. If it's itching all over and the diagnosis is 1A, there must be another cause why you're itching, not because the MF is returning.
Okay, that's good to know. Thank you.
And remember, dry skin is a real important cause of itching. It's a very common cause of itching, which people don't realize. So yeah, moisturize.
Definitely. Good to know. Thank you, Dr. Zain. My 16-year-old is treating MF with UVB and nitro mustard. It seems to be getting better. When do we stop the nitrogen mustard, and do we need to wean off or stop quickly?
I will say like, it's a discussion with the dermatologist, like that's directing the therapy. If the lesions are completely resolved, usually what I do is like I stop the topical first and then we know the light therapy. Or it depends also like how close are you to a phototherapy center, and like a 16-year-old might be like in school and it's difficult to get to the light appointment. So sometimes I win the light therapy first and then the topicals. But it's a discussion about like access to phototherapy, any side effects, and patient preference.
Okay, and another phototherapy question. If I have erythrodermic Sezary and I am slightly pink, is light therapy out or can it be done?
And well, light therapy is not first-line treatment for Sezary, but we use it especially in patients that are itchy, because light therapy helps with itchiness. In some patients, because the skin is already dry and many times it's cracked, like it doesn't help, but there is a subset of patients with Sezary that benefits from light for the, mostly for the itchiness. I would say, but Sezary needs to be treated.
Okay, Dr. Zain, anything to add on that one in regards to the Sezary portion?
No, I totally agree. I think you know, we have to basically treat the Sezary syndrome differently, but for itching, sure, light therapy would help. Yeah.
Okay. Let's see. Are there any nutritional recommendations for MF or to improve treatment results? What about phototoxic foods or supplements? Is that a real thing? Not sure which one of you would like to take this one.
Well, I am not aware of any specific, I'm not sure what phototoxic foods are. I don't think that's a real thing. I know there are people who are sensitive to certain foods and that, you know, can manifest itself as itching or rashes, which can confuse the disease or make it. So if you know that you're allergic to certain foods, then you need to avoid those. And that's, you know, that is only in that particular scenario. Otherwise, there's no specific foods that we recommend. We recommend that you be on a healthy diet, except if you are on targretin or retinoids, in which case you have to watch your cholesterol. And then, you know, because it does cause hypertriglyceridemia, if you're on that, and you may need to be on medication even to lower your triglycerides and cholesterol, and on a diet that you know, that will help you lower that, which is generally a Mediterranean diet. Other than that, we have no specific recommendations about any kind of food and nutrition. However, this question does come up a lot, and I understand it's very important for patients because it gives them something they can do for themselves. So I always recommend eat healthy, you know, lots of fruits and vegetables, you know, try to avoid sugars. Again, sugar does not feed cancer, but it's not good for your metabolism. So you want to keep your general health good so you can, you know, you can tolerate the treatments better. So you don't want to be diabetic, or you have high blood sugars because you eat a lot of carbs or sugars, or you are prone to that. It's just going to add to your morbidity and add to the side effects. But you know, so eat a healthy diet, exercise as much as you can. A healthy lifestyle is always going to make you tolerate the treatments better.
Okay.
And anything else to add by Dr. Seminario? If she can add something more, I'll be happy to hear her perspective as well.
I completely agree. We always we recommend like a healthy diet, like a healthy lifestyle, like you mentioned, like with exercise, good sources of like protein, like vegetables. I know some of our patients, sometimes they want to try some like infusions of vitamin C. Like I would recommend against those because you can have side effects of like trying to get like hyper doses of like vitamins. It's known side effect. So before trying anything, talk to your doctor. There's a lot of things on the internet that have not been proved to help, and on the contrary, they can cause some damage.
Yes, totally agree.
Okay, thank you both. We are going on a vacation that is sunny and we will be outside. I have MF stage 1A. Is it okay to skip the UVB treatment for the week? It's tough to carry the lamps in my baggage. Dr. Seminario-Vidal, do you want to take this one?
Yes, this is her.
Yeah, no, enjoy your vacation. Enjoy your vacation. Mental health is as important as your treatment. So enjoy it. 1 week, nothing will happen. Then you can restart the light therapy.
Wonderful. Thank you. Let's see. COVID vaccine, yes or no?
Yes.
Yes.
There are no contraindications to COVID vaccination in patients with MF unless you have CAR T-cell therapy or an allogeneic stem cell transplant, in which case we recommend that you wait 3 months after the transplant or CAR T. So there's very, very, very few people who fall in that category. Everybody else should be vaccinated. There is no contraindication to those vaccines, and they're very safe.
And if you are searching for more COVID-related information, Dr. Zain actually did a really wonderful COVID webinar for us, and you can find that on our live event videos on the webpage. Let's see, and I'm going to say this incorrectly, so I apologize, is Elicon and tacrolimus 0.1% a good topical for early MF, or are there any newer topical treatments that have been used in the recent past that I can bring up with my doctor for a discussion? So Dr. Seminario-Vidal, do you want to take this topical related question?
Yes. So I think there are like 5 type of medications that are on the National Cancer Center network guidelines for treating mycosis fungoides. I think topical steroids are the ones that we recommend usually first line, nitrogen mustard or meclorothiamine, that's FDA approved to treat cutaneous lymphoma, and topical bexarotene and imiquimod and retinoids have been used. So I think those are the first line. In some areas, like I personally also like the calcineurin inhibitors that were mentioned, but I only use it for some subset of areas that you cannot use the other areas, for example, like eyelids, which is rare for MF, but it's an area that there are limited options for treatment.
Okay. Anything to add, Dr. Zain, to that one?
No, I think that's pretty comprehensive. Thank you.
Great. Dr. Zain, are biopsies helpful if the patient is already treated with steroids? Can that confuse the reliability of the biopsy?
Yeah, so that's a very good question. That is actually quite, so it applies really to early stage disease where the patch plaque disease is present, and it can be confused with other types of skin problems where use of steroids can mask some of the some of the cancer cells, because steroids are a treatment for it's one of the skin directed therapies for MF. So you would ideally want to be off of steroids for about 7 days, topical steroids for about 7 days before a biopsy. But certainly, in more advanced cases where it's tumor stage, I don't think it makes any difference at that point, because the disease, the cancer cells are pretty, if you did, the volume of cancer cells in the biopsy is quite high, and topical steroids won't touch them. Yes, but in early stage disease, especially if the diagnosis is not clear, I think you want to give the pathologist as good tissue as possible, and avoiding steroids is helpful. Yeah.
Great, thank you. I've been recently diagnosed, with MF. Should I share with my endocrinologist monitoring thyroid and bone issues?
Can you repeat the question?
Certainly, yes. They are recently diagnosed with MF, and they would like to know if they should share the information with their endocrinologist who is monitoring their thyroid and bone issues.
Absolutely. So your doctors, all your specialists should know of all of your medical problems. So that's a general principle. There's no, they should know that you have MF. They may or may not, their treatments may or may not be affected by it, but certainly it's part of your medical record and they should be aware of it. The treatments that really affect your metabolism and would be treated by an endocrinologist would be diabetes if you're on steroids, especially high doses of steroids. Sometimes even topical steroids can be absorbed enough to cause problems, or thyroid issues if you are on targretin or retinoids. Similarly, long-term steroid use can affect bone health. So I think it's important for them to know what you're getting, to talk to your treating, to your specialist, just to make sure that you get the optimal care.
Okay, thank you. Are allergy shots contradicted in early stage MF patients? Not sure what that is.
Not to my knowledge.
No. I don't think so. No.
For a workup for MF, does a patient with patches or plaques covering 15% of their body, no enlarged lymph nodes, and normal flow cytometry need a PET or a CT for proper staging?
Excellent question. I would say no. Generally 10-15% is very early stage disease. If there's no palpable lymph nodes that the doctor can find, on their exam in the neck, under the arms, in the groin area, there is no reason to get a scan at that point. There is involvement of blood. There can be early involvement of blood, even in patch stage disease, in early stage disease. So make sure they check the blood for, involvement of with the mycoses. They should do a Sezary panel and look for gene rearrangements as well to see if the blood is involved or not. Again, it will be very early stage disease, but it's good to know for full staging. But a scan is not needed, in my opinion.
Okay.
Yeah, so I completely agree, but there are like some circumstances that will order like a scan, even if there are no palpable lymph nodes. If a patient has like some systemic symptoms that you can explain, or some abnormalities in the blood test. So no, I like overall I agree, but there are some things that will make us order a scan. And it would be, I think, and for NCCN guidelines, it should be covered by insurance too.
Yeah.
Let's see. My mother is 93 and has dementia. She was diagnosed with MF in 2016. She is on Valclor, alternating with steroids, with different steroids for her face. It's very challenging with the itching and the oral therapy. She also has had brachytherapy on some lesions, which is helpful. She is on acitretin. Thank you. Wondering about that age and cognitive population and any helpful hints. She is followed by a great team, but extremely challenging as a caregiver. She also gets prurigo nodules and bullous pemphigoid lesions from time to time. And I apologize if I said any of that incorrectly.
No, it's okay.
So I guess they're just sort of looking for some general, maybe recommendations regarding care at her age and cognitive.
Yeah, Lucia, you want to take that?
Sure. Like, so I'm just trying to put the whole history together.
Yes. I can repeat any of it. I'm sorry. I know it was long-winded.
No, that's okay. So I think, well, first, like you are doing like incredible work of taking care of your mother. It's always challenging to be a caregiver of somebody with dementia, of our most older patients. From the medications that were mentioned, like acitretin, not only helps the cutaneous lymphoma, but also helps the prurigo nodules. So I can see why the doctor used that medication. So it will diminish, and also sometimes we use it to prevent getting like skin cancers. The topicals, like the topical steroids, we use it also for bullous pemphigoid when it's limited. So if she has bullous pemphigoid and cutaneous lymphoma, I think those two options are a really good combination because they're treating like two diseases.
Okay, and she did also add that with the acitretin, sometimes it causes baldness and her scalp is itching, and she's wondering if you have any recommendations on what to use to clean her scalp.
Yeah, so like one of the side effects of acitretin is hair loss. So I think it needs to be balanced, like if it's helping with the other symptoms. So if it's diminishing the number of prurigo nodules and helping with the MF, and she doesn't care about the baldness, you can add a topical steroid to the scalp that will help with the itching. Sometimes, I think you also mentioned Valcor, right? That could be a little bit irritating. So you can talk with your doctor to see if they can take that off, because sometimes in the areas that you use it can create some type of irritant dermatitis. And since she's getting already acitretin, I think that will be her main treatment, the retinoids, and the topicals are more to relieve her symptoms. There are a lot of anti-itch medications that could be used, and you can discuss that with her doctor on top of the topicals, depending how bad is her itch, but that will improve her quality of life.
Okay.
Right, itching in a dementia patient, I'm sure, is going to be very difficult to manage. Probably makes her more confused. And
yeah.
Okay.
Yes.
Okay.
Let's see, another dermatology question. Stage 1A MF using UVB and nitrogen mustard. What is a typical timeline to expect complete improvement?
So,
if you're able to give one.
yeah, so studies have shown that light therapy usually give results between an average of 6 months. So I evaluate patients every 3 months when they are doing light therapy to see how they are doing, depending the involvement, the patient. Sometimes could be as early as 3 months, sometimes takes like up to a year to see complete response. To see improvement, I evaluate at 3 months. So it takes time. It's not a couple of weeks treatment, it's a few months.
Oops, sorry, I went on mute there for a second. Okay. On average, how long does a 1A MF remission generally last? If it returns, is it usually more virulent? Dr. Zain, do you want to take that one?
Well, I mean, again, every patient is different. This is one of those diseases where we really don't have predictive markers about who's going to progress. In my experience, you know, remission can be I can't really predict when a patient will come back. Their lesions will be small and they'll be usually generally very limited, even if it does relapse. It tends to come back in the same areas that it affects initially, usually in the back and the buttocks. Those are the most common sites. The sun, the areas that are not as exposed to the sun, and it seems to come back in the same areas. How long a treatment will keep working is kind of difficult to predict. That's why we always taper off treatments to see if the patient's symptoms start to, you know, come back again. So most treatments are tapered off for that reason. But that's all I can say. Most of the time, 1A remains as 1A. So let's hope that you're in that category. Yeah.
Yes. What would a T cell clonality panel show if you are in remission? Do the cells stop making clonal populations? I'm not
yes,
sure.
That's what remission means. Yeah, exactly.
Okay.
So if you're in remission, your T cell clonal population should go away or be undetectable. So the question is, where are you going to, which part of the body you're going to test it in, the skin or the blood? So if you have Sezary syndrome, then blood, you know, a negative blood indicates that the disease has gone into complete remission. If it's the skin, again, you have to do a skin biopsy and send it for and you also have to make sure that your pathologist uses the same probes to look for those gene rearrangements. So you have to really look at the lab results very carefully, but it indicates that you're in remission.
How often do you recommend checking the flow cytometry in the case of stage 1B?
Not very often. I think as I mentioned earlier, we do it kind of at baseline when we first see the patient or the patient first gets diagnosed to see if they have blood involvement or not. Generally, I don't order those tests in 1B patients unless their symptoms to suggest that there is progression. So worse itching, you know, if the itching gets worse, if they start to develop erythroderma, or if their skin lesions get stage changes, you know, if they become more aggressive, at that point, we should always check the blood again and make sure that it's not starting to show involvement.
Okay. Let's see. Which test is indicated to determine if there is progression from MF to Sezary? Is there a test for that?
There's a blood test so Sezary syndrome is basically blood involvement. So you would check for the involvement of blood and see if it meets criteria for Sezary syndrome. Also, the patient would have erythroderma. They would be red from head to toe. They may have, the skin may become dry, much more drier, itchy, and the lymph nodes can start to get enlarged as well. But it's really the blood test that determines the Sezary syndrome.
Okay. Dr. Seminario-Vidal, someone has said, I have red patches all over my face, even on my eyelids and onto my neck as well. What is a good, safe facial cleanser that I could use without irritating my skin any further?
So first, I assume these red patches are from mycosis fungoides. And so I will try like any of the gentle ones. Like there are several brands that have like hypoallergenic face cleansers, like some that I can name without any conflict of interest are like CeraVe, Cetaphil, Aveeno, Vanicream. Those are hypoallergenic. So that's what I will recommend.
Okay. Thank you very much. Any other recommendations, Dr. Zain?
No, I'll leave that up to dermatologists.
Okay. Preferred topical treatments, 1A or B on the body, on the face. Is a cream version or ointment better? Dr. Seminario-Vidal?
So it depends. If your skin is like oily, I usually prefer creams, lotions, or gels. If your skin is dry, like ointments are better. And the main reason behind that is because you will feel it better and you will use it. If your skin is oily and you're putting an ointment, most people will not like to use the ointment. They will not put the treatment. So then it's not working.
Okay. No questions here, but this has been really great. Thank you so much. Thank you. Let's see. My PCP feels that I am not a cancer risk and that I should not be concerned, but I am. How should I respond back? I've been silent on it. I'm terribly frustrated. Either of you want to give any insight on this one?
I didn't quite hear the question because my internet connection was a bit. Can you repeat that?
Yes, my PCP feels that I am not a cancer risk and that I should not be concerned, but I am. How should I respond back? I'm terribly frustrated.
So is this a patient with MF?
I believe so.
Okay, and I'm not sure which particular cancer they're talking about. I mean, every patient should also be screened for regular cancers that they should be screened for. Age appropriate screening should happen. So women should be getting mammograms and the pap smears, and men should get regular prostate exams and at their appropriate age, as well as colonoscopies for both men and women. So skin exams are also important. So an MF patient should have all that screening done as part of their routine medical checkups. Now, in terms of an added risk, I think they may be referring to the first, the similar question we had earlier, whether there's an increased risk of cancers in patients with MF. And again, there may be an association with some of the hematologic malignancies for which there is no screening. Mm-hmm. And then the skin, if you're getting, light therapy, there is risk of skin cancers that should be discussed with your dermatologist.
Okay.
So, yeah.
Let's see. Can I use bexarotene with PUVA, stage 1B?
Yeah. Yes.
Yeah, we mentioned that before, that it's a great combination, like a higher response rate than one or the other alone.
Okay, great. Thank you. When I have a relapse with new skin patches, I get intense throbbing in my armpit along with the skin patches. How common are these symptoms? I get relief for the skin patches on the short term with steroid cream. What can I do, if anything, to get relief from the throbbing in my armpit? It's very painful.
That's interesting, because that's not a common symptom. It sounds like your lymph node is getting inflamed at the same time as the skin patch. So one of the things that I would do is have your doctor make sure there is no infection in the skin lesion. They can do a swab. Sometimes there's a staphylococcal infection, which can cause the lymph nodes to be enlarged and inflamed, and can be treated with some antibiotics, or maybe there's MRSA that should be checked for. But usually for patch stage disease, we don't see very many enlarged lymph nodes. So I'm sure that the doctor has examined the armpit for lymph node enlargement, and I would discuss it with them and see what they think is going on. But it's a very unusual symptom.
Okay. And just to give everyone a heads up, we have about 5 minutes left. Let's see. I have developed growths on top of both fingernails and toenails. They are unsightly and annoying. What can or should I do about them?
Growth.
Dr. Seminario-Vidal, do you want to start with this one?
Yeah. So can you say somebody has developed growth?
Growth.
Yeah.
Correct. On top of fingernails and toenails.
Yeah, like I don't know if it's like inflammation. There's something called paronychia. That's inflammation of the nail fold that usually could be caused by infection. Sometimes we can see it in patients with Sezary syndrome, and we treat with high dose topical steroids. extremely rare. One of the side effects of the oral targretin could be pyogenic granulomas that look like small, like blister, usually it's on the side of the fingernails, and those are treated also by dermatology with sometimes with cautery or topical retinoids. So I will suggest first step will be to get that evaluated by your dermatologist to determine what type of growth and best treatment.
Great, thank you. Let's see. I had total skin electron beam therapy in 2009. Is it still very important for me to avoid sunlight? Dr. Seminario-Vidal?
And it depends how your skin is looking. If you're in complete remission, congratulations, and you will not need to avoid sunlight. We recommend avoidance of sunburns, but going in the sun is perfectly fine.
Okay. Let's see, probably have time for one or two more questions here. What are the most effective treatments for patients whose biopsy showed FMF in the scalp and face and MF in other areas of the body? Is there a topical that is safe to use on FMF skin around my eyebrows without making the skin look bad?
Yes, and I think like we mentioned earlier, like FMF goes deep in the skin. So if it's extensive involvement, I try to avoid topicals. If it's just located in the eyebrows, sometimes I try gel retinoids that go deeper. But if it's several areas, like I prefer some systemic therapies, and you don't need to worry about topicals. You can do like a systemic therapy that will help those areas, like oral retinoids, for example.
Thank you. Let's see, does diet have an impact on flare-ups? You know, we sort of talked about the nutrition portion. Dr. Zain, do you have any advice for this one?
No, I'm not aware of any associations. Some people do. I've had a few patients who feel that certain foods make their disease a little bit worse, and I think that may have to do with food allergies, causing, you know, skin rashes, etc. That makes the itching worse. So if you are aware of something like that, it's best to avoid it. But in general, there's nothing in the diet that actually will make your flare-ups worse.
Okay. All right. Last question here. What do most patients find to be effective for incessant itch? It's a tough one.
It's a tough one, yes.
Yes. Dr. Seminary, do you want to start with this one?
Sure. So this is our nightmare as doctors, the itch, because every person itching, is different and it's really bad. So we want to help everyone, but we need to try different things. So I always try combine topicals with oral medications depending on the type of itch, like topical steroids, also good skincare, like Dr. Zain mentioned earlier. Dry skin contributes to itch, so we need to always think itch could be multifactorial, just not CTCL. Patients with advanced itch are more itchy because their skin tend to get drier. So dry skin care, like we have some instructions, what things to avoid, what type of moisturizers are good. Topical steroids help with itch. Light therapy will help with itch. And then by mouth, oral antihistamines, some medications like gabapentin we use for itch. We use sometimes medications that help with anxiety and also with itch. And also we use sometimes like a stronger, like sedating steroids before bedtime. So it depends on the patient, on the severity of the itch, if it's waking the patient at night or not, how we will treat it. But it's like several steps that we follow, and it will be a discussion with the doctor based on the symptoms and the severity of symptoms.
Great. Well, this does bring us to the end of our session. Dr. Seminario-Vidal and Dr. Zain, thank you. We are eternally grateful for your expertise and spending part of your Saturday here with us today. So thank you so much to you both.